A very good evening to all, and I heartily congratulate Dr. Raju Tyagi, Niharika, and entire being organizing one of the great academic feast in Lucknow. I realize I am not being able to be with you physically due to some very urgent and unavoidable commitment. Lucknow Society with Dr. Rajul, with Dr. all our teachers, Dr. Chandravati, Dr. Manju Shukla, Dr. Uma Singh, and all galaxy of teachers, Dr. Shyama, Dr. Nidhi, Dr. Priti, and always it is a great pleasure to be at Lucknow. So this is all memories what we have in the in Lucknow societies, and what is I have learned from the teachers and the mentors that a leader leaves no one behind, and you have been all inspiration in my 30 years journey in FOGSI. So coming to shoulder dystocia, do we think that we are not going to have shoulder dystocia in modern practice? Actually, no. We are going to be more and more shoulder dystocia, and it is going to be an increasing clinical and medical legal importance. Shoulder dystocia, both things are equally important for the management of shoulder dystocia. We need extreme remedies for the extreme situation. So we have only 5 minutes right from diagnosing to managing and delivering the baby. So both are golden words in context of shoulder dystocia. It remains poorly defined, unpredictable, difficult to manage, at the same time potentially devastating and medical implication for patient and family. Fortunately, not quite common, yet suddenly and to be taught and predicted. And this is important that we have to have the drills about it. Defining and designing shoulder dystocia, what is incidence of shoulder dystocia? Actually, it is not that easy because the simple things can be very, very complex. So how we define shoulder dystocia, that is when additional maneuvers are required for the delivery of shoulder of infant, when there is a failure of gentle downward traction on the fetus affecting delivery of shoulder, or when there is a prolonged head to body interval delivery time that is more than 60 seconds, or when we have to use any maneuver. So there are many definitions, but I will like to draw your attention on very, very important statement that the gentle downward traction for the fetus delivery, for the delivery after the delivery of fetal head, should not be done for diagnosing it, because that process itself can cause the brachial plexus injury. So that is the Sevas in 2018, a wonderful paper which he says, and what he says that we don't only have the a very high quality research academic, people who are really working in labor room, their statements are so very important, and he says very, very loudly, there should be no traction on the head to diagnose shoulder dystocia. Incidence can be 0.2 to 3%. No ethnic difference is there, and still it is something very important that very common cause for the in obstetrical practice. Evidence seem to be increased in last 2 decades. It is around 2 to 3%, and why there is more incidence, more big babies, increasing use of epidural, deliveries in supine position. So now we are really looking for a midwifery case-based care and an alternative position. More babies are of the larger weight, and the 10% of babies can be more than 4.5 kg. Maternal diabetes is an independent risk factor for shoulder dystocia. So we are having around 10 to 15% of the GDM in our population, and that cause decreased head to shoulder ratio, higher body fat, thicker upper extremity skin fold. Intensive treatment for maternal diabetes reduces the risk for macrosomia and shoulder dystocia. So we are going to have more shoulder dystocia, and that's why this topic and this thing and that shoulder dystocia drill is very, very pertinent topic in today's high risk obstetrics. What is the issue? Why the large size baby have the shoulder dystocia? Because the shoulder, all the 3 diameters, the pelvic brim anteroposterior diameter is narrowest and the transverse is widest. So average gynecological pelvis, the inlet AP diameter is 12 centimeter and transverse 13 centimeter, and average size fetus has got bisacromial diameter of 12 to 15 centimeter. So shoulders are usually in anteroposterior diameter above, and they transverse then to the larger transverse diameter. So although the bisacromial diameter is larger than the transverse diameter of the pelvic inlet, so transverse pelvic, although the bisectoral diameter is larger than the transverse diameter of pelvic, there is no obstruction because shoulders and they are pushed towards the fetal chest. So it is a tight fit, and when in GDM or in large size baby, when bisacral diameter is large and the shoulder confront pelvic brim, there is a chance for the shoulder dystocia. Iatrogenic shoulder dystocia, what Seva says very strong, that if you do the gentle downward traction on the fetal head, that can cause, so you are not diagnosing shoulder dystocia per se, but it can cause the extension of brachial plexus and can cause the brachial plexus injury. And this important message I wish to everyone. Beside this, the compound presentation and sometimes phenomena like sacrococcygeal teratoma or fetal ascites can cause the shoulder dystocia. Risk factor for the shoulder dystocia, it should likely start from the antenatal period. Maternal obesity is a risk factor. Around the relative risk is 2.3. The small mother is also a risk factor, which is very, very important issue to be considered in Indian scenario, because fetus is larger for a small mother and the more chances of prolonged labor and operative intervention. Maternal diabetes, again I say this is very important and it sets the stage that we should control the blood sugar level in the antenatal period very meticulously. What is the cutoff for macrosomia? So ACO per se it is 4.5 kg and the 5 kg, but for our scenario, our Indian women, the 4 kg for the diabetic and 4.5 kg for the non-diabetic mother, and of good consideration. Diagnosis of the fetal weight is another important thing, because when there are medical legal issues, they will say why you didn't do the cesarean section when fetus was macrosomia, or you anticipated shoulder dystocia. So what is the thing, that there is always a 360 to 400 milligram, there is a inaccuracy, and actually ultrasound like measurement, yes, it is close to the estimated what is the fetal gestational weight, but it can never be very, very accurate, and that actually adds that we cannot say that we are going to have the elective cesarean, or what caution predictable like measures we should take in the labor. So the prediction of fetal macrosomia should include all the factors: diabetic status, prior history of macrosomic infant, maternal pre-pregnancy weight, what is the weight gain during pregnancy, multiparity, post-date is young. So it is the ultrasound estimation, but the other clinical scenario, clinical spectrum is also to be looked at. Male fetus is also having a higher weight, higher the fetal weight, advanced maternal age, and the prolonged pregnancy. A woman with history of shoulder dystocia or brachial plexus can have the recurrence rate is around 10.1%, and we have certain tool to predict. So usually it is usually encountered in absence of risk factors, though we have devised certain tool, and that is the all combination factor, that is historical, prenatal, intrapartum, and all clinical scenarios should add to what is the risk factor for the shoulder dystocia. What we can modify the risk, we can set in our antenatal care. So correction of BMI, measure to reduce excessive weight gain, good control of GDM are few things what we can have. But if we reduce induction of labor, oxytocin augment, prolonged labor, like avoid prolonged labor, and we are careful that there is no prolonged second stage of labor, that can also reduce the incidence of shoulder dystocia. Can we do something prophylactic? So in prolonged pregnancy, in the GDM, prophylactic induction of labor, and prophylactic cesarean, what we say it is around 4 kg in diabetic mother and 4.5 kg in non-diabetic mother. Yet the studies does not say that we do just for the like a ultrasound weight assessment and do for the elective cesarean section, it is a late Faustian bargain, because we have to do around 27 extra cesarean section to prevent one case of brachial plexus injury or the one case of the fetal hypoxia. So the counseling and the informed choice to be given to the patient and the family. Why it is a obstetrician nightmare? Because fetal risk are immense. Brachial plexus injury, clavicle fracture, humerus fracture, fetal hypoxia, fetal and neonatal death. And important point which I wish to give the message to the all, that if the delivery is completed within 5 minutes, chance of serious fetal injury or fetal hypoxia is very less. So it is a 5-minute time which is important. However, if the baby has been hypoxic before the diagnosis of shoulder dystocia, this 5 minutes can be up to the 3 to 4 minutes. But if the baby is not hypoxic before the presence of shoulder dystocia, you have 5 minutes, and that minutes need to be have a very, very coordinated and step to deliver the baby. So don't stress the thing till the elasticity breaks. So brachial plexus injury, what I say, that never do the unnecessary traction, never give the gentle downward traction. So this is very, very important, because traction itself cause a regular stretching of the brachial plexus, and the incidence of the abduction palsy can be quite high, around 10%, and the average range of disability is 5 to 50%. Fracture can be the very common complication, and the fetal asphyxia and the plexus injury have a potential serious sequence. However, and sometimes the fracture of the clavicle is one of the disparate measures. Maternal complication can be there due to PPH, vaginal cervical lactation, or genital tract trauma, and the long-term fetal and the fecal incontinence. How to diagnose? So one of the very, very important in all high risk cases, you anticipate, and 24/7, even in low risk case, we should be ready with our shoulder dystocia drill. When you anticipate that after delivery of head, with or without assistance, and chin are delivered with difficulty and head is sucked back. So that is a typical turtle sign. So if you suspect, when you anticipate shoulder dystocia, suspected large baby, slow progress of labor, precipitate delivery, instrumental delivery, and classical turtle sign. And never pull hard and never push hard. This is very, very important thing. So what to avoid? Pull, push, panic, pivot. So these are the 4 things which we need to avoid. And now our time starts now. That is the 5 minutes. So we have to say what time you have, so that you can do for all the things, that is a helper drill or the alarmer drill. So one is call for help. You have to have certain people to assist for everything, for the all pressure and the maneuver, neonatologist, anesthetist. Episiotomy is something when you are anticipating that you have to give certain maneuvers, then episiotomy is okay. Otherwise, shoulder dystocia is a bony obstruction. That is a McRobert position, and in all high risk cases, this McRobert position to be given, that is maternal hip protected and acutely flexed by bringing knees toward the chest, can be done by nursing staff, and it is something which gives to you the space into the pelvis by the rotation of the anatomical diameter. So it increases diameter of the pelvis, and it rotates symphysis superiorly and straighten lumbosacral angle. So McRobert maneuver is fine, and should be the McRobert position actually, because not but maneuver we don't want. I will say again and again that don't give the gentle downward traction, any traction, but the McRobert position is adjuvant, which actually helps in prevention of shoulder dystocia as well as treatment of shoulder dystocia. The second is the suprapubic pressure. It needs a push, like it's on the stool. You have to lie of the fetus and apply steady pressure on the right, so that you have to give with the heel of clasped hand or from the posterior aspect of anterior shoulder, and you like from the side of fetal spine toward base. So this is the position the assistant is standing on the stool, and it is important to be above the woman when performing suprapubic pressure, and it has to be given from the right side. No fundal pressure to be given. Never and never cut nuchal cord. That will always a fetal hypoxia and chances of fetal death. And then this is the thing that how you do the next maneuver are on the simple principle that the posterior below the sacral promontory and anterior shoulder is above. So all offset maneuver, that is the based on that principle, and we have the rotational maneuver and arm extraction maneuver. So what is the thing on the principle that the posterior shoulder is below? So you rotate the posterior shoulder from the 180 degree normal anterior shoulder, which is stated above pelvic. Anterior shoulder become anterior, and that's why you can cover the fetal head. So that's the principle of wood screw and the reverse wood screw, that depend upon that what you are facing with. So when there is a obstetrician put the dominant hand into the left side of maternal pelvis, head will be against posterior aspect of posterior shoulder, while in the wood screw method, it will be the posterior aspect, anterior aspect of the posterior shoulder. So that is a rotation based on the principle what we use in the offset maneuver in the breech extraction. If the wood screw or the reverse wood screw does not help, then the next measure is which we have to resort immediately, that is the extraction of one of the arm. This is like a not that difficult method, and some studies say, many authors advocate that the delivery of the posterior arm should be our first, like it should be prior in our menomics. So usually anterior arm is too difficult to reach behind suprapubic arch, and usual approach is to deliver posterior arm first. So it is a maneuver which we have to treat into the drill, that you are turn and support fetal hand, follow the shoulder to humerus, apply pressure to antecubital fossa, then grasp forearm and sweep across baby's chest, and once the posterior arm is delivered, the transverse diameter of shoulder is reduced and you are able to deliver the baby. So delivery of posterior arm allow rotation of fetus with aim of infection, but there should be no direct grasping and pulling. The one should not pull on the head. This procedure can cause the fracture of clavicle or humerus, but fracture are manageable, but not the brachial plexus injury or the hypoxia. If you are not able to do so, the posterior axillary traction has come in a big way in the menomics of the shoulder dystocia management, because it is easy. You put middle finger into axilla like hook and pull down posterior shoulder with overlapping fingers, and this is coming with a good like a result. And sometimes you can use a suction catheter under axilla together above the shoulder. So axillary sling traction is something very simple, and it can cause a fracture. Yes, it can cause the fracture, but it has got a very good result, whatever experience we have, and we should be knowing about this technique. Sometimes all four maneuvers, so putting the patient on the desk can also effectively increase pelvic dimension. The cause issue is that the time lost in repositioning and immobility if the epidural anesthesia. But we should remember that sometimes really it helps. Measure of last resort, sometime to save the life, that is the clavicular fracture. Juvenile maneuver, that is cephalic replacement followed by cesarean section. Hysterectomy for abdominally assisted maneuver, symphysis or the cledotomy. Somehow we are using art as well as courage for doing all procedure. It's okay. We want to have a good risk assessment, good prediction, good preventive measure, and the following of the menomics. Issue in the shoulder dystocia is that never and never like cut the cord. So it is very important. And secondly is that when we have the babies delivered by shoulder dystocia, this is very important message I want to give, that usually what we do, we immediately cut the cord and hand over the baby to neonatologist. In shoulder dystocia, actually the resuscitator should come to the, and we should give a time so that the placental blood flow comes to the baby, because even the shoulder dystocia is managed in less than 5 minutes. Few babies are born without pulse and cannot be resuscitated. So this is one very, very important point I wish to convey, that the shoulder dystocic baby are severely hypovolemic, and the resuscitator should come to the labor table. We should give around 30-second time so that placental blood reaches to the blood and the neonatologist have a better baby to the resuscitate. Document well, patient deserve accurate and immediate information, what happened, what procedure you have done. If you think that brachial plexus injury is there, we should not speculate regarding cause, and vigilant watch for mother. Mother is always very important for PPH tear and hemodynamic status. When you encounter shoulder dystocia, take a good time to document once the delivery is over. What was the position of fetal head delivery? Which shoulder was anterior? Time of delivery of fetal head? Staff was done. What measure were done at time of delivery? What maneuver? Newborn weight? Any difficult motion of extremity, disposition of newborn, any maternal complication, and cord blood pH, because it is going to save you from the medical legal case. We cannot emphasize importance of obstetrical drill. We are having a wonderful Manyata session, and our center, Jeevan Jyoti Hospital, has trained on around 50-60 facilities. So join Manyata so that your all staff has got the drills and know what to do. So to sum up, shoulder dystocia is an obstetrician nightmare, serious emergency. Predict and prevent if possible. Deliver in do not pull at all, do not clamp and cut the cord, anticipate ahead, diagnose in time, macrobot maneuver, suprapubic pressure, delivery of posterior arm, foot screw map, jacquemer can be proper order of maneuver. After 5 minutes, you can think of the syphilis, and after baby is born, do not immediately clamp and cut the cord for 1 minute. Wait the baby so the baby is auto-transfused through the placenta, and resuscitator start resuscitation at mother's bedside. With this, I seek your full-hearted support coming election for the FOGSI president. They say the world has become too complex for simple answers. No, they are wrong. Our professional body needs now the simple person who has commitment and conviction for the women health of our country, as well as the fellow obstetrician and gynecologist. Do vote and support my candidature. E-voting is 1st August to 10th August. And thank you always for being together.